Bismillah ar-Rahman ar-Rahim. Hello and welcome to my lecture series in Obstetrics and Gynecology, Dr. Azdihar Sahmi Hamoodi. Our lecture today is about amniotic fluid disorders. This subject can you find in your book 10 Teachers, Chapter 6, Antenatal Obstetrics Complications, Oligohydramnios and Polyhydramnios, page 189. In order to understand this subject, I will give you a short introduction about amniotic sac and amniotic fluid. What is amniotic sac? The amniotic sac is a bag of fluid inside a woman's womb, thus to say the uterus, where the unborn baby develops and grows. It's sometimes called the membranes because the sac is made of two membranes called the amnion and the chorion. The amniotic sac starts to form and fill with fluid within days of a woman's conceiving. What is amniotic fluid? The amniotic sac is filled with a clear, pale, straw-colored fluid in which the unborn baby fluates and moves. Amniotic fluid has many important functions. It helps to cushion the baby from bumps and injuries and maintains constant temperature for the baby. It also helps baby's lungs, digestive system, and musculoskeletal system to develop, so it is vital for healthy fetal development. However, if the amount of amniotic fluid inside the uterus is too little or too great, complications can occur. And these are the main topics of our lecture today. The learning objectives that you are must to know are the definition of amniotic fluid, functions, clinical importance, how to assess the amniotic fluid abnormalities, thus to say oligo and polyhydramnios, their diagnosis and treatment. Objectives that you are nice to know are the volume and composition of amniotic fluid. This lecture will be of two parts. Part 1 will cover the polyhydramnios and part 2 will cover the oligohydramnios. Fetal membranes. Fetal membranes are structures that develop from the zygote and do not share in the formation of the embryo. So that's to say they are extra embryonic structures from the primitive blastomeres. This picture shows you these two layers. The outer thicker layer called the chorion, and the inner thinner layer called the amnion that cover and surround the amniotic cavity. Here the umbilical cord and the placenta with chorionic plate from the fetal side. Here the maternal side, the endometrium, decidua, and maternal vessels. And here the feto-maternal circulation through the placenta. This picture shows you again the normal membranes that surround the embryo and the abnormal membranes here where the amniotic membrane injured for some reason, torn or ruptured, so that fibers or bands coming from it towards the fetus and surround any fetal part, especially the extremities, that lead to um, prevent development of them or sometimes ischemic changes and even amputation and lead to delivery of a baby with deformed extremities. This syndrome is called amniotic band syndrome. It's a very rare condition. So the amnion and amniotic cavity. So the amnion is a membrane which bounds the amniotic cavity and it is continuous with the ectoderm of the embryo. As you know from your embryology, the fetal layers are three: endoderm, mesoderm, and ectoderm. The outer one is the ectoderm, and from this layer come the amniotic membrane. What is the definition of amniotic fluid? So, amniotic fluid is the fluid that's surrounding the developing fetus and found in the amniotic sac inside the uterus of the mother. What are the physical characteristics of amniotic fluid? It's a clear pale yellow fluid. Its pH around 7.2, so it's faintly alkaline. The specific gravity of it is around 1. What is the composition of amniotic fluid? About 98 to 99% of it is only water. The remaining 1 to 2% is solid substances like inorganic and organic salts, fetal epithelium protein, and enzymes. The water in amniotic fluid completely changed or replaced in every 3 hours. The origin of amniotic fluid, it comes from amniotic membranes, maternal tissue, interstitial fluid by infusion across the aminochorionic membranes in the decidua, filtered from the maternal blood vessels, and also secreted from the fetal respiratory tracts, reach up to 400 milliliter daily. And fetal urine daily output at term reached to 1,200 milliliter. So the largest amount of amniotic fluid comes from the fetal urine output. By week 20, most of the amniotic fluid become from the urine output, from the fetal urine output. The circulation of amniotic fluid. The amniotic fluid formed by amniotic membranes, as we said, and filtered from the maternal blood vessels, accumulate in the amniotic cavity. And then it will be swallowed by the embryo and pass again to the amniotic cavity as fetal urine output. The volume of it will increase slowly from 50 milliliter at the end of first trimester of gestation, reach to 400 milliliter around week 20, reach to 1 liter at term, and then decrease again at the expected date of delivery around week 40, and then decrease much more when the baby is post-date. This schedule show you the increment in amniotic fluid volume with the increment of gestational age. What are the functions of amniotic fluid? Before labor, it forms an isolating bag around the embryo, protecting him from the external trauma, injury, shock, and maintains temperature as we said before. It prevents adhesion of the embryo to its surrounding membranes and allow homogeneous media needed for the growth of the embryo and permits free movement needed for the muscular exercise. And during labor, it forms bags what's called forewater and hindwater. The bag of forewater allows regular dilatation of the cervix. Why? Because of the pressure on the cervix, it will stimulate the cervix to produce prostaglandin, which is very important in the dilatation of the cervix during labor. During uterine contraction, it prevents the interference with the placenta circulation because it prevents the pressure of the direct pressure of the fetus with the umbilical cord. After rupture of membranes, the amniotic fluid serves as a lubricant for the descent of the fetus, and also it is bacteriostatic. What is the clinical importance of amniotic fluid? It's used for screening for fetal malformations by measuring the serum alpha-fetoprotein, assessment of fetal well-being during ultrasound examination by measuring the amniotic fluid index, assessment of fetal lung maturity by measuring the lethicine sphingomyelin ratio, diagnosis and follow-up during labor. Also for diagnosis of PPROM, which is a preterm pre-labor rupture of membrane, by searching about a special protein found in amniotic fluid. So if this protein is found, Ferning tests become positive and we will confirm the diagnosis of preterm rupture of membrane. Diagnosis of fetal chromosomal abnormalities like Down syndrome, Edwards syndrome, and others. Also DNA studies for diagnosis of some single gene disorders. This slide shows you some markers measured by amniocentesis in amniotic fluid to test the well-being and maturity of the baby. How you assess the volume of amniotic fluid? Clinical assessment is unreliable. Objective assessment depends on ultrasound examination and measures. We have two measures, either by deepest vertical pool or deepest vertical bucket, or by amniotic fluid index, and this is a total of deepest vertical bucket in each four quadrant of the uterus. It is more sensitive indicator for volume of amniotic fluid throughout pregnancy. This picture shows you how to measure amniotic fluid index. You will divide the abdomen into four quadrants and then measure the deepest pool in every quadrant, and then gather all the four quadrants measurements, and the total will be the amniotic fluid index. So we have two deformities of amniotic fluid abnormalities, either polyhydramnios or oligohydramnios. Polyhydramnios will be the subject of our lecture part 1, and oligohydramnios will be the subject for part 2 lecture. Polyhydramnios defined an excessive amount of amniotic fluid, 2 liter or more, and the amniotic fluid index is more than 25 centimeter. That's to say, more than 95th centile for gestational age. And the deepest bucket or the deepest vertical pool will be more than 8 centimeter. The normal value for amniotic fluid index is between 5 and 25. So more than 25 is polyhydramnios. And the normal value for deepest vertical pool is 2 to 8 centimeter. So more than 8 centimeter mean that you have polyhydramnios. In case of oligohydramnios, which is reduced amniotic fluid volume, the amniotic fluid is 5 centimeter or less, thus to say less than 5th centile for gestation. Again, we say that the normal value between 25 and 5, so less than 5 is oligohydramnios, and the deepest vertical pocket is less than 2 centimeter because the normal value is 2 to 8. So less than 2 is oligohydramnios. This picture summarizes to you the meaning of polyhydramnios, which is the excessive amniotic fluid surrounding the fetus. You see here large amount of fluid, and the fetus is swimming in this large amount of fluid. You see the large abdomen and excessive stretch markers, stria of pregnancy, symptoms of polyhydramnios. And this ultrasound picture showing also polyhydramnios. You see the deepest pocket, deepest vertical pool is very large. It's definitely more than 8 centimeter. And you see also there is congenital anomaly. You see here micro gastric. That's to say the stomach is very small. That's to say this baby have a disorder or anomaly in its GIT, maybe duodenal atresia or esophageal atresia that lead to polyhydramnios. So, what is the etiology of polyhydramnios? About 60% idiopathic, 20% fetal anomalies in different systems, CNS, GIT, skeletal, cardiac, or renal system. Diabetes is a common problem. Maternal diabetes, of course. Maternal multifetal gestation in case of twin-to-twin transfusion syndrome. That's when this twin pregnancy is monochorionic twin pregnancy. Immune, non-immune hydrops, fetalis, fetal infection, and placental tumor example, chorioangioma. So, from fetal anomalies, about 50% of fetal anomalies is anencephaly. In this abnormality, there will be transudation of the exposed meninges, lead to polyhydramnios, or absence of fetal swallowing reflex is the cause, and suppression of fetal antidiuretic hormone. In case of open spina bifida, there will be also transudation from the meninges because of exposed meninges. Problems with swallowing and GIT absorption, like esophageal or duodenal atresia or tracheoesophageal fistula. Increase in transudation also in hydrops fetalis. In twin-twin transfusion syndrome, as we said, in monochorionic twin pregnancy. Also, there will be polyhydramnia because of fetal polyuria in the receiver twin. In the receiver twin. What are the symptoms of polyhydramnios? There will be dyspnea and palpation in the mother, abdominal pain because of large abdomen and abdominal distension. This may lead to contractions and preterm labor. There will be decrease in perception of fetal movement. How can you make your diagnosis? By symptoms: dyspnea, edema of the legs, varicosities of the legs, vulva hemorrhoids, abdominal distension, large abdomen, and signs and symptoms of preterm labor. Abdominal examination, you will see that the uterus is very large, larger than the expected for date, and difficult in palpation of fetal parts, difficult in hearing fetal heart, and the fetus will be palatable because of large amount of fluid and the baby swimming in this fluid. The skin of the abdomen become tense, shiny, with large striae of pregnancy. With ultrasound examination, you will see excessive amount of amniotic fluid. As we said, the largest pool, deepest pool, will be more than the normal. Also, you may see fetal abnormalities. What is the effect of this polyhydramnios on the fetus? Fetal prognosis worsen with more severe hydramnias and congenital anomalies. So 15 to 20% from fetal malformations that found already in the fetus, the effect of a preterm delivery on the fetus, all its complications. If there is diabetes, there will be effect of diabetes and its complications on the baby. There is a risk of prolapse of cord. So all the risk with cord prolapse and its effect on the baby, even from distress up to death of the baby, and the complication with abruption and its effect on the baby that lead also to the death of the baby. Effect on the mother, again, the placenta abruption and its effect on the mother, bleeding and so on, uterine dysfunction and uterine atony, bleeding and so on, postpartum hemorrhage, which is the complication to the above complications, and abnormal presentation of the baby because of large amount of fluid that may lead to operative delivery, thus to say cesarean section. What are the types of polyhydramnios? It can be mild when the deepest bucket reach up to 11 centimeter, moderate when the deepest bucket is up to 15 centimeter, and it's called severe when the measuring of deepest bucket is above 16 centimeter. But this is only 5% of cases. For example, in twin-twin transfusion syndrome in monochorionic twin pregnancy. How can you manage a patient with polyhydramnios? If the polyhydramnios is mild to moderate, rarely requires a treatment. You can hospitalize the patient in case in conditions like in case of diabetes mellitus. So in this case, she will need bed rest and the treatment of associated condition, controlling of blood sugar and so on. You can give non-steroidal anti-inflammatory drugs to reduce the fluid. And the last choice, in case of severe cases of polyhydramnios, you can do amniocentesis. Amniocentesis means that you will draw fluid by special needle from the amniotic cavity under ultrasound control in order to relieve the maternal distress and to do test for fetal lung maturity. You will draw only 500 milliliter per hour and not more than liter or 1.5 milliliter per day. What are the complications of amniocentesis? You may cause ruptured membranes. You may induce infection, what's called chorioamnionitis, and you may induce placental abruption. And preterm labor, which is the complication to the previous complications. You can give, as we said, non-steroidal anti-inflammatory drugs like indomethacin. This will impair lung liquid production and enhance absorption that will lead to decrease amniotic fluid amount. It will decrease fluid movement across the fetal membranes, but it has several complications like premature closure of the ductus arteriosus, impairment of renal function, and cerebral vasoconstriction. So it will be not used after 34 weeks gestation. If the gestational age is more than 37, consider termination of pregnancy, for example, induction of labor. Well, with this slide, I finished my part one lecture. I would like to thank you very much. Thank you very much for your attention. I wish you good luck in your study. Goodbye.